Good afternoon, everyone. Thank you for being here. This meeting today is focused on the city of Goleta and issues related to homelessness. My name is Landon Rank. I'm the director of programs at SB Act, and this is a partnership with the city of Goleta. So we also have with us Chuck Flax, who's the homelessness services coordinator. Um, Today really is focused on mental health and homelessness and the intersection there. And so we're going to be hearing from a couple of different local experts and then sort of talking about who to call and what to do if you see an issue in the community. But I do want to name before we get started too that although these issues intersect, we can't conflate them either. Not all of homelessness is caused by a mental health or behavioral health issue. And in fact, in many cases, homelessness is actually the cause of some behavioral health issues, or at least correlates with an increase in behavioral health issues. So it's important for us to just note that these are separate issues, but definitely intertwined. So as we start today, we have a couple of different folks that'll be talking. We brought in, asked some partners from the County Department of Behavioral Wellness as kind of our lead mental health, behavioral health experts in the community. And then we also will be hearing from law enforcement in a little bit about how they respond to mental health related concerns as well. Generated a kind of simple flyer with sort of who to call when that I'll be posting after this. But just wanted to note there are a few phone numbers that are going to be really important for you to save on your phone if you don't already have these. And we'll be talking through each of these scenarios. So with that, I don't know, Chuck, if you have any other words of introduction you want to say before we turn it over to Jean and Eric. Oh, you're muted, Chuck.
Thank you, Landon. Welcome, John Lansky.
Thank you.
I have some things to report about Goleta, but we'll wait until after the presentation from the behavioral health folks.
So let's go ahead and go to Jean and Eric, and I'll let you introduce yourselves and I'll pull up the slides.
So, hi, I'm Eugene Morales. I'm the Homeless Services Program Manager, and I also oversee the Housing Assistance and Retention team that behavioral wellness contracts with telecare and some of the housing related issues. And then Eric.
Yeah, hello. My name is Eric Rowan, and I'm the team supervisor for homeless services at Be Well.
And so we have a slide presentation that tells a little bit about what we do. So the department is really undergoing a lot of changes, especially with BHSA coming online. And we're working hard to integrate
I told you I want 12 to 1.
mental health treatment with substance use, housing, all these things that combine to treat the whole person, right? And so it's really a whole person approach. Previously, before I was with behavioral wellness, I was working for LA County DMH, working for their whole person care program, which I'm glad to see that statewide, most of the behavioral health systems are moving towards this approach. If we can go to the next slide. So looking at this slide is really kind of presenting the mental health system as a managed care system. So the Department of Behavioral Wellness, we serve serious mental illness, so individuals with moderate severe mental illness. And CenCal is the managed care plan for individuals with low or no income. They serve mild to moderate mental illness, and both systems are interconnected. And with BHSA coming online, we're more interconnected than ever, where there's a lot of coordination going on. And it's really important that we have our clients and clients across the board connected to CenCal because there's community supports available that they qualify for, that it's part of their plan. And many of those folks will also qualify for enhanced care management. And some of those community supports involve housing related resources and also rental assistance resources. So when you think about it, we're actually we're actually all working for the insurance, for SenCal. We bill SenCal, and we're a provider. And I think that's a big change in the system. One of the things is we've all the behavioral health systems in the state have undergone payment reform. And so there's a big push not to have duplicative services, right? But individuals who are connected to SenCal with like the community supports, they still also qualify for behavioral wellness services. Uh, any questions on that at all? Or okay, we could go to the next slide.
Yeah, this slide here is talking about ways of accessing the system. For most Be Well referrals or access, people are going to call our access line. It's the top one there. It's a 24-hour crisis response and services access line. So if someone wants mental health treatment, if someone wants treatment for substance abuse, and if someone's experiencing, some level of a crisis, that would be the line to call. Now, obviously, if someone's level of crisis is higher, where there's an immediate danger to themselves or others, it may rise to the level of a 911 call. And I don't know, Gene, if you had any further comment on that, but that's the way I understand it.
Yeah, and so I think depending on the, whether it's a mental health, crisis, or there's that immediacy, if somebody's actually in danger, you do definitely want to call 911. But if you call the access line and somebody's, maybe voicing suicidal ideation or something like that, that's a good step to help them getting assessed and making sure that they stay safe. Um, so I guess we'd go to the next one.
And this slide here kind of talks about the focus of my teams. Um, so we're obviously trying to work with unhoused individuals and getting them enrolled with Medi-Cal, and they have to have the moderate to severe mental health condition, persistent mental condition. They also often can and do have co-occurring substance use disorders. Those are our kind of target population. The focus of the homeless services teams at Be Well is to stabilize with mental health services, linkage to shelter and interim placement and permanent housing. And we're a short-term program, so typically once they're in permanent housing, we are looking to step them on to the next program. So that would be linkage. So it could be our Calle Real clinic. It could be going up if they have a lot of serious needs. It could be to our FSP2, which I think may eventually be called an ACT team again, but that's changing. Sometimes it's a step down. They go down to a SenCal provider. Sometimes it's PathPoint as another step down. It depends on how the client's doing by the time they're in permanent housing. If they're doing better, then they probably step down. If they're not doing better and there are a lot of challenges, they might step up or go over to Calle Real Clinic. And then lastly, just so people know, there's two programs at Homeless Services. We have the MDT team and the regular homeless services. So there's two referral forms, and typically most of the referrals go to the homeless services, general homeless services. That's where most of the referrals go, because most of the MDT referrals actually become internal referrals from public health or from public defender. They running into people that they feel meet the 2 out of 3 criteria for MDT multidisciplinary team. They need to have a mental health, serious mental health condition, a physical health condition, or legal involvement with the courts through public defender. They have to have 2 of the 3, and then they can qualify to be on the MDT team. Our general referral process is from our partners in town. Typically, they come from Good Samaritan, CityNet, City of Goleta, City of Santa Barbara, people like that, new beginnings. We've been a little behind. We kind of got overwhelmed a little while back when we added beds at Hedges House and Dignity Moves. I think some people thought, oh, I want to get my client housed right away, just refer them to Be Well, and we got flooded with referrals. So we're still trying to kind of dig out of that, doing the best we can. I did gain an employee, and I'll mention that as when we go forward in a minute. There's more staffing, but at the same time, I gained one. Before that, I lost one and a half, so it still was a net loss. But we're doing what we can do. So that's probably enough on that sheet, that slide. Okay, so the staffing. So I'm supervisor for the whole county for homeless services. I have one assistant, AOP, like an administrative assistant. North Region, I have a caseworker, an AOD specialist, and a practitioner, although that practitioner has left. So I'm looking to fill that with a therapist in North County. West Region, I have a caseworker and a practitioner, same problem that that therapist is left, and I need to find another therapist to fill that. So I am looking for those two. And it is on our county website if you know anybody interested. And we can take people who need to get their hours once they've completed their education at a counseling school. South Region, I have two caseworkers, two practitioners, a psychiatric nurse, and a peer support specialist who's the new person that we just added. And we have a psychiatrist and a PA that covers the psychiatry in North and West. So that's pretty much the whole team countywide. And so it's a little thin, but things keep changing. And under BHSA, who knows what may change. But we're adding one peer just happened. And I think we will have an ad going out at some point for another caseworker for South County too, because the housing piece keeps growing on us. So, Gene, did you have a comment about any of that?
Yeah, absolutely. So our staff wear a lot of hats. So they work as the primary liaison for the behavioral wellness programs because we have several outpatient programs and the clinics as well, like the FSP teams, the Justice Alliance teams. And so our homeless services staff, they act as the liaison for in the shelters. And then as Herschel can attest to, they're in the shelters daily and all the different sites. And we have several sites where we contract and have bed placements for our clients. And so they're wearing a lot of different hats. We collaborate with the housing authorities very closely. As Barco, I mean, they're very supportive of us and us of them. They do an amazing job. And as we're talking right now, they're leasing up for Patterson Point, which is a wonderful thing. They're doing a great job. And so there's a lot of collaboration going on behind the scenes that a lot of people don't see, but um, our folks are wearing a lot of hats. And beyond that, once they get leased up, they're still our clients, and we still want to make sure that they're accessing services. And one of those things, as I alluded to before with SenCal, is making sure that those folks are also linked to the enhanced care management or the community supports with SenCal, because that provides another level of services for them. So previously, we were contracting with Telecare to provide like tenancy sustaining services with the heart team. And as BHSA comes online, that funding source won't be available, but the state has decided that, well, we want the managed care plans to provide that service. So we can't provide a service that the managed care plan is providing, right? That duplicative service thing. So that's why we want to make sure that all our folks are connected to SenCal and the community supports as well as the ECMs if they can. And then will also have staff on site and also our teams at Patterson Point. So we've brought in a peer, and so he'll be on site working that, doing the liaison piece and making sure that, we have like a tenant education program that we're also has training his Barco staff to implement as well. And so working together with them and so it's a collaborative process that it's ongoing. And there's bumps in the roads here and there, but really it's amazing, and we're really thankful to have these partners in the community. They're great. Um, anyway, I'll keep talking if you let me. So let's go to the next slide. And so these are numbers from 24-25 on the number of services for the homeless services mental health outpatient team. And as you can see, they're like in the South, over 1,000 services per quarter, right? And then I think in quarter two they dipped to about 860. So these numbers, they're good numbers and they're respectable. But I can tell you that these numbers are low compared to what we're doing now, right? So as I mentioned at the outset, we've gone through payment reform, and um, I think our staff are probably knocking these numbers out. I haven't pulled the recent numbers, but they are the numbers are definitely going up. Um, and so even though we've lost staff and we're replacing them with staff, it, it's a mix, but um, they do a lot of work and they wear a lot of hats. And so I think the numbers actually reflect it. If we can go to the next slide. So these are the sites where we have contracted beds, right? So at the Casika Shelter at Mercy House, we have like 17 beds there. Salvation Army, we have beds. Hedges House of Hope, Dignity Moves, La Posada, um, Bridge House. We're picking up some cabins over at Rainbow Village, Hope Village, Santa Maria Emergency Shelter. So our homeless services staff, they act as the liaison for the wellness clients at these locations. And so that in itself is a big job, but we're also, they also have their active caseloads and also the MDT clients and also coordinating with the community. Like we'll get calls from Chuck once in a while, right? Hey, we got this guy over here. Can you follow up on him? Or we'll get it from other community partners, from the hospitals. Um, we're very collaborative, and so it's just kind of I'm trying to paint the picture of this team really actually does a lot of stuff, and there's a lot more to come. They're going to be doing a lot more as BHSA comes online. Um, and so they may look at me and they're like, "What are you putting on our plate now?" But there's a lot coming down the road. Um, so if we can go to the next slide. We got okay. So talking about the sources like CityNet, Good Samaritan, Public Health, Virgil Cordano. We get a lot of referrals from Virgil Cordano in South County. Obviously, coordinated entry. Our staff are participating in coordinated entry, helping our folks to get housed or to qualify, get document ready, which is huge, right? The public defenders, hospitals, all the hospitals, Marion, Lompoc Medical Center, um, they they know our staff by face, and they know how to reach them. And let's see. So our FSP teams and the SUDRAP teams, the substance abuse treatment teams, are actually starting to be more involved with HMIS, which is really important because we are the primary provider for substance abuse treatment in the county. And so even though it's not necessarily this homeless services team here, our SUDRAP teams, if you call that access line number, these folks can also access substance abuse treatment, which includes linkage to contracted providers. And there's, if they're unhoused, there's placements for them if they're participating in those programs, if they qualify for those services. And so it's that same access line number that you would call. It's 1-888-688-1649, I believe. Yeah. And so that's the central access point. And again, we really have strong partnership with his Barco, and we're working to try to make it stronger and improve it. It's been a learning process for us, and thankfully they're patient with us. And they're, I have our staff have nothing but good things to say about them because they do a lot of good work. And I know that, it's not always easy managing folks with different and complex needs, right? And so I think that, it's a process for all of us.
And can you say more what MCP and BHSA are?
So MCP is the managed care plan. So that's
Okay.
Central. Yeah. And so BHSA is the Behavioral Health Services Act. So Prop 1 that was passed, and it's going to come into effect on July 1. It was previously the MHSA, which is that 1% tax for the millionaires that it actually funds our mental health programs. Now it's BHSA, and BHSA has a lot of requirements around diverting a portion of the mental health budget, basically about 30% towards housing interventions, and it's not services, it's housing. So it's not necessarily like we're having all these support teams for housing. It's mainly and a lot of that's already allocated. There for like housing placements, maybe some of the locations, for instance. I think we're opening up a ARF, which is Tecolote House, and then there's other projects that are in the works. But it's anyway, that's BHSA. So it's Behavioral Health Services Act. Sorry about my stuttering there. And so, okay, so connecting to enhanced care management, the ECM, which is CenCal, it's a big priority because our folks will qualify for like community supports. So if we can go to the next one. And this just kind of like highlights some of the different levels of service that behavioral wellness has throughout the county. So prevention and wellness services, outpatient services like the clinics. So each region has outpatient clinics. We have like Central and Lompoc. They just had a grand opening for their new location. They have family services. They have adult services. TAY, also crisis services. In Santa Barbara, we have, the Real Clinic. We have the FSP teams, Justice Alliance. Justice Alliance is countywide. Homeless services countywide as well. And then in North, we also have the outpatient clinics up there, and same array of services. SUD throughout the county, again, going through that access line. They have a whole array of services as well as recovery residences and supports for folks. They have as much as, if not more, placements than we do that list you saw of our shelter placements. So there's a lot of treatment for substance use, as well as outpatient services, whether it's MAT, linkage to AGIS, which is the primary methadone provider in the county. And so let's see, intensive treatment services, the PUF. So if folks don't go to the PUF, maybe they might go to a placement outside of county. They may go into like the CRT placements. We have the crisis residential facilities that located throughout the county. So in Santa Maria and Santa Barbara. And I believe there's also Champion Center. So if we can go to the other next slide. And you click on that again. And so the highest intensity would be like the psychiatric health facility, 16 beds. As you can imagine, that probably gets full, right? And so then we send them across other places like Las Encinas, which is in Pasadena. It's a nice facility. Vista Del Mar. If we can click on the next one, another example of a crisis stabilization unit, or the CRT, which is the crisis residential facility, which is like a 30-day stay. So if somebody's stepping down from the PUF, it's appropriate for them to go like the CRT, which would be like a 30-day step down to help them stabilize. And then maybe they would go into the, let's say, the next one. You can click on that one. Maybe a residential treatment facility or rehab, or even someplace like La Posada, right? Which is maybe longer term, but any folks that go into La Posada, we case conference around to make sure that they're trying to make sure that they're appropriate for that level of care. So if you can see that it's kind of stepping down, and then we have to go to the next one. Um, the lowest level of intensity, that's permanent supportive housing. It takes a while to get there, right? As we know, anybody working in the housing business, it takes a while to transition, and not as fast as we would like, but that's kind of the way the system looks. And then if we can click on the next one more time. And so this is an example of some of the locations. And so if you can see the ones that are highlighted in blue, which are those permanent supportive housing sites, those are all HESBARCO sites. And then we do a lot of coordination with them on those locations. There's some of those units are pointing towards Be Well clients. And then the other locations, they're step down board and cares like Jenny's or McMillan Ranch, um, you know, Good Sam Recovery Point, Phoenix House. Um, and we don't have Teclodi in there yet, but it will be. And then, of course, there's the PUF with the highest level of care. And just kind of like the locations throughout the county.
For Goleta, you'll have to add Buena Tierra and Patterson Point.
Right? Well, the thing is, the reason why we have these listed and we don't have we should have Patterson Point, but the reason we don't have Buena Tierra is that we didn't have a commitment to be at the location for Buena Tierra. Although we do have clients there, not as many as one would think, but one of the things ongoing is making sure that our outpatient clinics and teams are connecting with the clients where they live. And that continues to be a focus, and it's going to continue to be even more of a focus as we go forward. Because our homeless services team is great and they do a lot of work to wear a lot of hats, but those outpatient clinics are seeing them regularly and they're their regular treatment providers. And we want to make sure that they're connecting with them and also collaborating. We have to get ROIs, releases of information, and make sure that we can collaborate with the housing authorities, both city and county. And so we have good relationships with the city housing authority as well. And 3055 De La Vina is going to be coming online probably, I would say, early July. And we'll likely have clients there. And so we're going to want to make sure that we honor our commitments to them and our clients in the community to make sure that we're supporting those folks. So we go to the next one. There you go. So talking about that, the 22 units, 11 are Housing Healthy California, 11 are Homekey, Be Well level of care. The De La Vina projects are Homekey Plus. And then there's some coming down the pike in the future. I hope my numbers are right. I'm trying to get the ones, especially for like Heritage Ridge, a lot of units. Then the Hollister Lofts, Hollister 2. So there's a lot to look forward to in permanent supportive housing. The other piece too is also trying to build relationships with landlords and community. So these are subsidized, housing. They're supported for those folks that are able to stabilize and able to earn employment and also help them with income, and they're able to. We want to encourage them and help them to move on to independent living. if possible, because that makes room for more folks that we can help. And so part of this is trying to build relationships with landlords in the community. Um, and it's a process because there's a lot of education that has to happen. And then also providing support for those folks to make sure they stay stable and they can afford it's expensive to live here. So it's expensive for all of us. And so making sure that they can afford to live. If we can go to the next one.
Okay, yes, the coordinated entry system. And we know Catherine's on this call, so she knows she's in charge of that. Before I go a little bit deeper into that, I just wanted to speak to all that we've already said. Um, with the BHSA coming on July 1st, and that's largely how BWell is going to be funded. What has happened is we had the allocation toward housing is great, but they did not put into that much allocation for support staff for that housing. So basically, the homeless services teams countywide are now funding themselves through the billing CenCal, Medi-Cal. They're doing billable services. And so that's one of the limitations that is on us. It's great that we're able to fund our own jobs going forward. That's wonderful. But like our outreach has kind of fallen off, that is not a billable service to go out and do outreach. So we still do it on occasion, but most of our stuff is by referral. And our referral partners, they're the ones that we're relying on very heavily for outreach to the community in terms of going into the riverbeds and going under the freeway overpasses and doing the direct contact on the streets in general. I think it's, Good Samaritan and CityNet and others are doing that. We used to do a little more of that, but like I'm just saying, things have changed. We basically have been told you need to pay your way. And we are, and it's a good thing. But I'm just showing a picture of how my teams are stretched. On the one hand, I'm after them about you've got to make your hours this week to fund your position, and you need to do all these other things like the CES meetings are wonderful, and my team members go to the CES meetings, and this is how most of our housing is done. Before the last year or so, I think we were still getting a lot of people into Hotel de Riviera and other properties because there were vouchers. Now that we're in the land of no vouchers coming down the pike, everything has switched to CES and getting people into Hasbarco properties or City Housing Authority properties. And so we're very involved, and my team is doing all these things, going to the CES meeting. They're going into HMIS. All of my team members are trained and operate in HMIS, and they're upgrading their clients' data and information to keep them on the community queue so that when an opening happens at Patterson Point or 3055 De La Vina or wherever the next is, their clients are in HMIS, they're in the community queue, which is the bottom of the slide, their community queue, which means that they can be drawn from. If they're not in that community queue, then HCD is not going to be drawing from anybody who's not in the queue. So you have to be in the queue to get into that property. So getting people ready, doing the homeless verification, doing the verification of disability, all the different things that need to be done is a lot of paperwork, and they call it being document ready. But that's a whole thing. And then it has to be updated. Things drop off and they need to be updated. So, Gene, did you have anything about this?
Yeah, and I guess just to kind of piggyback on that, it's targeted outreach, right? And that takes the collaboration. So for instance, and when you think about it, for instance, Chuck, if you're giving us a call, right, and you're pointing us to a location, like if we have somebody to go out there and look at it, or one of the outreach providers, Landon, or let's say CityNet, they're like, or even in like the CES meeting, sometimes we'll get information, like we'll be able to do that targeted outreach. We'll get calls from like the Goleta or City of Santa Barbara or Lompoc, and or the community providers, and so then that we send the staff out there. Otherwise, we it's not like we can be out there just driving around, right? We want to use what we have in a way that maximizes what we're doing. And so we also contract with a lot of providers. For instance, like we have a lot of contracts with Good Samaritan, we have contracts with various providers throughout the community, and so that definitely helps. Um, if we can go to the next slide. Going back to the linkage to SendCal. This I'm trying to make this in there. I can't emphasize this enough. And so these are links. There's links in here. So it has like the referral forms and the for the different populations within the uh, member services and member services contact information. So that's the other part of the system, right? So if you're thinking mild to moderate and moderate to severe, but the community supports part also applies to the moderate and severe populations. And so that's we want to make sure that those folks are linked in because that's also going to help them retain their housing. It's really important. Let's go to the next slide. So this is some of the stuff that's coming out online with BHSA. So as I had mentioned before, there's a lot of requirements for Be Well with BHSA, the Behavioral Health Services Act, Proposition 1. And I'm thinking about one when somebody named this, they must have thought about it as Proposition 1 as e pluribus unum or whatever, but it's one system. So we're you're thinking substance abuse treatment, field-based substance abuse treatment, focusing on individuals who are unhoused, forensic ACT teams, the FACT teams. An ACT team is like the highest level of care. It's a community-based treatment delivered, with people with complex behavioral health needs. Those are the ACT teams, and then the forensic part of it is those folks that are justice involved. And so we have requirements where we're going to have these teams working out, meeting people where they're at. So it's more of a field-based approach. And I know there's probably a lot of people in the community that are happy to hear this. I'm actually somebody who's spent a lot of my career out in the field, and that's primarily where I've been. And so this is um, this is going to be interesting. It's a good thing. It's a good development. Um, another big emphasis is on individual placement and support employment services. Excuse me. So helping people, obtain employment or also whether they qualify for SSI or those sorts of incomes also help, department wide, we're trying to make sure that people have the ability to have funds so that they can live, right? Because it does, if somebody goes into a housing placement and they only make $50 a month, I'm sorry, but they're going to be having a problem, ongoing. So we want to make sure that we have supports for them so that they can actually have some income. And these are evidence-based practices. And there's a lot of reporting requirements that go with all of these programs. But they're going to be we're going to be standing them up and they will be operational. So the CARE Act, and this is a question that comes up a lot, and I was talking with Chuck about this the other day. And I'm not trying to throw you under the bus, Chuck, but he's like, well, why isn't it successful? And I don't know that it's not successful. I think that it's managing the expectations of the community. So the CARE Act isn't a panacea that's gonna fix everything. Because I was thinking like, wow, we're gonna be able to pull a lot of these folks that have severe issues and pull them off of the street and get them into treatment, right? And part of it was it because it's, because they, have to provide consent or, it's optional. So I think putting in context, it's another tool in the box to help folks. It's not going to solve everything, but it's also good. It's a good thing. Excuse me. Eric, is there anything that you'd like to add on that or?
Yeah, I mean, I wouldn't be surprised if some point down the road they tweak it a little bit. It's a growing thing. It's relatively new still. It's a growing edge, and there's improvements can be made for sure.
I think one of the things is so a lot of folks can follow the petition. First responders, family members, a licensed behavioral health provider, public guardian, adult protective services, somebody living with the individual or the individual themselves. And then if NAMI has an act that, well, you can contact the access line. NAMI has a drop-in, and they also provide support with uh, getting getting support for filing a petition for that, and also the public defender's office. Maybe we can go to the next slide.
Yes. Again, circling back to those two phone numbers. I mean, the access line is the everything line for Be Well. You want to refer someone for mental health, they want to call and they want to do residential or outpatient drug and alcohol treatment. If they're kind of having a crisis in the sense of suicidal ideation, they can call. And what happens when they call the access line, they will be diverted to someone who will actually do an over-the-call assessment and a way to determine where is this person at and where should they be directed, if appropriate, within the Be Well system. So it is the hub, it's the main way in. And I know like out at our shelters, that we like La Posada, sometimes you'll call because there's a ongoing crisis with a particular client, and maybe that's better served by the caseworker for that client to come out and work with that client. But sometimes, they'll call the access line, and if it sounds serious enough, a crisis uh, team might come out and they'll do an assessment. And if they determine that the person's not really in a danger to themselves or others at that time, they may not take them. I know there's this misconception. If crisis comes out, they're going to put them on a 5150 and take them somewhere. Not always. I mean, they will if the person rises to a certain level, then they would. But if they don't rise to that level, they may sit with them for a while and do an assessment with them and decide not to take them. And that's their expertise to make that decision. Now, obviously, if someone's really a threat and it's dangerous, I mean, please call 911. What would you say, Gene?
So I think one of the things that to keep in mind is they're always looking for the least restrictive level of care for the person, right? Provided that we're talking about safety here, we want to make sure that the folks are safe, but they're looking for the least restrictive setting. So that they may, they may say they might take them to the hospital, they might go to the crisis stabilization unit. It could be a variety of things that could happen. They may safety plan with them, and also notify, if there are caseworkers there or available, and then follow up. So, I mean, yeah. And I think that might be the last one, resources. So I provided a couple of resources in the PowerPoint, and information on the Act and Fact teams that are coming down the road. The Count Mesa dashboard actually shows a lot of the homeless information data on the um, uh, actually statewide for homelessness. And then the behavioral health member handbook for Be Well talks about the services that individuals qualify for. And then a little bit of the chronic homelessness verification, just to understand what people are talking about and how we categorize them. Well, I mean, we kind of have to in order for placement. So, and I think that's it. And thank you for listening to us.
Well, thank you both. In the interest of time, I do want to go really quickly over to our law enforcement side just to hear kind of what they can offer in terms of responding to mental health services. So I'm going to turn it over to Deputy Warden.
Morning, everybody. I'm Deputy Connor Ward with Santa Barbara Sheriff's Office. I'm the Community Resource Deputy for the City of Goleta. And Eugene and Eric already touched on what we can offer. That's essentially the second part of what they were talking about, is if you feel the need to call 911 because someone is in immediate danger to themselves or others because of a mental health crisis, or you call the access line, and during that assessment, the access line determines that. And our behavioral science unit then, what we'll send out is our crisis intervention team. And our crisis intervention teams are a trained deputy. That's their full-time job. And they also are partnered with a behavioral wellness clinician. Sorry, I'll turn down my radio. So the behavioral wellness clinician and the deputy will respond, and they will assess the person. And essentially the framework they're working under is Section 5150 of the Welfare and Institutions Code. So if during that assessment, the behavioral wellness clinician determines that that person is an immediate danger to themselves or others because of a mental health disorder, they will place them on a 5150 hold, and that person will be transported by AMR to Cottage Hospital, where they'll be further assessed by the psychiatrist on staff there at Cottage Hospital to determine if they need to stay on that 72-hour hold. We have 4 crisis intervention teams, 2 in the north part of the county and 2 in the south part of the county. They're on every day of the week, so sometimes there's overlapping. Sometimes there's 2 on in the South County and 2 on in the North County. And they work from 9 to 7 about those times, because running all the call logs, that's when we determine that the call volume is highest for mental health issues. So that's when they're around. Even if they're not on, what we still do is if you call in the middle of the night because you call 911, you think someone's having a mental health crisis that would be necessary for them being placed on a 5150, we still have deputies respond, and behavioral wellness still has 24/7 response to our clinician will come out and assess that person. So that's what we provide. We don't have anything specific to homelessness. Like Landon said at the beginning of this, it affects mental health, affects everybody. So it's not just specific to homelessness. So, but that's how we work with behavioral wellness.
Thank you. And then I think the other final resource we wanted to mention in terms of who to call is Chuck and City Homeless Services. And so, Chuck, do you want to just talk briefly about when would a community member call you?
So community members can call me at any time. I mean, I don't work the same kind of hours, and I'm not an emergency resource. But if anybody's concerned about homelessness in Goleta, they should call me or email me. And we, as people know, we respond very quickly. We work closely with all these different partners, including the outreach partners on call here. And even if someone isn't homeless but is demonstrating unusual behavior or potentially a threat to themselves or others, I'm more than happy to support community members. So I'm always available during regular business hours.
Thank you. So I will put those numbers up on the screen once more. I think
Thank you.
the diagram I made may need to be tweaked based on some of what was shared today, but I did want to have us end on a somewhat positive note, or Chuck wanted to have us end on a somewhat positive note. So we did want to talk about what Gene mentioned in his presentation about the permanent housing opportunities that are opening up very soon, that will have some more resources for those experiencing mental health needs. So I'm going to turn it to John from the County Housing Authority to talk about some of those projects and then what some of those services will be that are offered there on site.
Hi, everyone. John Polanski, Director of Housing Development, Housing Authority of the County of Santa Barbara. And I want to shout out to Eric and Eugene. Yes, you are correct. It's back at you. We really value our partnership with Be Well and actually, quite frankly, with the Sheriff's Department. Unfortunately, we also have to get the sheriffs involved from time to time. As we all know, everybody is different. Everybody stabilizes and moves forward differently. And there is no set handbook on how people are going to move from step 1 to becoming more self-sufficient. So really appreciate the partnerships. So it's really, the services that Eugene and Eric mentioned as far as Be Well. Be Well is an important partner with all of our permanent supportive housing projects. Patterson Point is a particular example because I think it's half the units are tied into No Place Like Home and the Be Well clients. So right now, as we speak, lease up began this morning to the development. Patterson Point, unfortunately, we always encounter some hiccups with new construction. I also can't predict those, just like we can't necessarily predict how people are going to act as they stabilize in permanent supportive housing. We also have some hiccups, but fortunately we're getting folks moved in. We hope to be fully leased up with the 23 non-manager units by the end of the week. That's a pretty rapid pace. And I know we have it's all hands on deck, which is why you're stuck with me today. So, in addition to the case management services, we do some, clearly, one-on-one case management is really vital because everybody is different. But then we also have some group opportunities. We really encourage our new residents to get to know each other. We find that everybody, including myself, are very food motivated. So if we provide pizza and soda or something like that, most of our residents will come out and participate. So we, work with public health, who's not on this particular call, but they do some, healthy cooking, hygiene, the variety of different things. We find that conflict resolution is important for our new folks coming out of experiencing homelessness. Some folks have forgotten that the way we behave within communities of tenants is different than one might have to behave when they're not currently housed. So that certainly is something that's really important to us. But the stabilizing factor of having our partners like Be Well, Good Sam, others, where the folks have grown to trust the individuals that are helping to support them, that really helps the transition into permanent supportive housing because they will get to know the housing authority and they'll get to know our staff, our resident manager, the resident services team. But we're not the ones who have gotten them to the point of being in the CES and ultimately housed. It's that warm handoff from Be Well and from the other partners that is really important. But then at some point with the stabilizing, we'll get into, some resume building to hopefully get that, at least a part-time job going for the folks that can. Computer literacy, online banking has become so important. So we have folks trying to do that. So it's a variety of support services provided by some of the financial institutions, some of our community partners. So we're really excited. Anytime a new permanent supportive housing development comes online, we're really excited about it. But we never know what's going to happen. So we really appreciate the partners being there because that's the thing we all know. Everybody is different, and we celebrate the differences, but just look forward. And one of the things I do tell people, when unfortunately we sometimes do have to, we do have some cases in which a behavior is so unacceptable that they can no longer stay housed, and that's simply because we have to be concerned about not only the individual but our staff, the other residents, and our neighbors. And because we want to keep being able to do permanent supportive housing. And the only way we do that is build on success. So again, really appreciate the partnerships and everybody who's on the call. That's it for me. I could also, like Eugene, I could go on, but I won't. I'll try to self-monitor.
Thanks, John. All right, so we really only have a minute left. I know some of our service providers may need to jump off, so please feel free to do so as needed. But I do want to make sure if there are any questions from the community, feel free to raise those now. And even if our service providers need to jump off, we can at least field those and get you answers later. So any questions? Not seeing any at the moment. So I'm going to put back up that slide that I had created. Give me 1 second to pull that up. And just to note those 4 phone numbers, I think that the cases in which you would call these is slightly different than is presented here, but I think it's worth just jotting them down anyway. So have 911 for the situation where someone presents a danger. We have the behavioral wellness access line in green. There's also the sheriff's non-emergency dispatch as a resource if it's not an acute, danger situation. But you see that there may be something concerning, and then Chuck as a resource. For example, if you're seeing someone day after day on the streets who you think may be suffering from a mental health related need, it might be worth reaching out to Chuck and just making sure he's aware. He likely is, but it's always helps to present it. So. Anything else while we're all together? Chuck, anything you wanted to share?
No, I mean, we're out of time for today, and that's fine. Something that we didn't get a chance to really talk about is that people still see people on the street who seem like they're still suffering, and why can't we do something to help those folks? And I've said on the record that we don't give up. That people have the opportunity to reject services. That we live in a state that's very much in favor of people's individual rights, and that means that until someone is really ready, we can't necessarily force them into treatment unless they're going to hurt themselves or somebody else, really, or if things are so dire. And that can be heartbreaking to see. But I really appreciate everyone who presented today, because I know you all really care, and that when we do have an opportunity to address somebody, you all take advantage of it. And we always, try to get a hold of them and talk to them. And sometimes we can't, but we keep trying. We're not going to give up on people.
Really quickly, Chuck, building on that, when people are housed, the other thing that's a little bit of a misconception is that we can force people to accept support
Right.
services, and that is a condition of them staying housed. And that is not accurate. That cannot be a condition of staying housed. But as I explained to individuals who decide they no longer need the supports that they clearly still need, we will not evict you for not accepting support services. However, if your decision to not accept the support services that are available and oftentimes brought to our site for your convenience, and it leads to behavior that then ultimately causes the eviction, that is what would cause the conviction, the behavior by not accepting the support services. So that's been my message that I give to community meetings. That's also the message I give to residents at some resident meetings when I feel the need to do so.
Well, thank you all for participating, and this was very informative. I hope, Landon, we have access to the slides and can provide them to people if they're curious. And I just want to thank everybody for helping out today.
Thank you all. Have a great week, everyone.
Thank you.
Thank you. Bye.
Yeah. Bye-bye.